All right, welcome to the Explainer. If you're a medical trainee trying to get your arms around gastroenterology, this one is definitely for you. Today, we're going to break down the key high-yield updates from the brand new 2025 ACG guidelines on managing Crohn's disease. Okay, let's jump right in.
So, we're going to walk through this just like you would in the clinic. We'll start with how to actually nail the diagnosis, and then we'll talk about the new treatment goal, a really big deal. We'll cover the key therapies, tackle a couple of major complications you're absolutely going to see, and then we'll zoom out to cover preventative care and, treating the actual person. First up, diagnosis. And right off the bat, the guidelines make one thing super clear. There is no single magic test for Crohn's. It's all about being a clinical detective, piecing together different bits of information to really build your case. Okay, the words you really gotta latch onto here are progressive and destructive. This is the whole ballgame. You have to understand that Crohn's isn't just some on and off inflammation. If you don't get it under control, it leads to permanent, irreversible damage to the bowel. Our job is to stop that from happening.
So what's going to make you think, this could be Crohn's? Well, the guidelines point to these classic symptoms. When you see this cluster in a patient, especially things like weight loss, anemia, or growth failure in a younger person, Crohn's needs to be right at the top of your list. The workflow here makes a ton of sense. You start with your clinical suspicion. Then, you use fecal calprotectin. It's this fantastic non-invasive marker that basically tells you if there's active inflammation. If that's high, you go to ileocolonoscopy to actually see it and get biopsies. And finally, because the scope can't see everything, you need cross-sectional imaging, like an MR enterography or MRE, to map out the entire small bowel.
All right, this next part, it's probably one of the biggest shifts in how we think about IBD care. For so long, the main question was just, hey, how are you feeling? But the new guidelines are pretty much screaming that that is nowhere near enough.
The whole goal line has moved. We're shifting away from just getting symptoms under control to achieving what's called mucosal healing, which just means when we look with a scope, the ulcers are gone. So why the big change? Well, it's because we've got solid data now showing that when you heal the bowel on the inside, you get much better long-term outcomes. We're talking fewer hospital stays and fewer surgeries. And this isn't just an opinion. This is straight from the guidelines based on a ton of evidence. A patient can feel completely fine while their bowel is still full of inflammation, just simmering under the surface, causing permanent damage. So the take-home message is huge. You have to look. You have to treat what you see, not just what the patient is telling you. Okay, so we know the goal is mucosal healing. How do we actually get there? Well, the guidelines lay out a really powerful arsenal of medications, especially for those patients with moderate to severe disease. Let's do a quick flyby of the main drug classes. For anti-TNF agents, the big pearl is that for a new patient, using it in combination with an immunomodulator works better than using it alone. Then you have anti-integrants, like vedolizumab, which are awesome because they're gut selective, but just know they can be a bit slower to kick in. Anti-IL-12/23 agents, like ustekinumab, are real workhorses for both getting people better and keeping them better. And finally, the oral JAK inhibitors, like upadacitinib, are a potent option, especially for patients who've already been on an anti-TNF that didn't work. So yeah, treating that straightforward inflammation is one thing. But, on call, in the clinic, you're going to see the really tough stuff, the destructive side of Crohn's. So let's dive into two of the trickiest but most common situations you'll face dealing with perianal fistulas and trying to prevent the disease from coming back after surgery. This might be one of the single most do not mess this up points in the whole guideline. If there's an abscess, a collection of pus, you must have a surgeon drain that infection before you even think about starting a powerful biologic. Giving an immunosuppressant when there's undrained sepsis can be an absolute disaster. Rule number 1, control the infection, then treat the inflammation. All right, next up, surgery. And here's the thing you have to hammer home with patients. Surgery isn't a cure. It fixes a problem, like a stricture, but the underlying disease is still there. And without proactive treatment, it will almost definitely come back. So, how do we stay ahead of it? The guidelines say you do a colonoscopy about 6 to 12 months after their surgery. And this is the number you need to burn into your brain, the Rutschgert score. If you see a score of I2B or higher, which basically means more than just a few little ulcers, that is your objective trigger. That's your green light to start or escalate their medical therapy to stop it from coming back. Okay, so we've talked a lot about the gut, but great Crohn's care can't just stop at the colon. Our patients are often on drugs that suppress their immune system, which means we've got to be super vigilant about all the other stuff, all the proactive health maintenance.
And look at this. This shows a huge gap in care, but it's also a massive opportunity for us, as clinicians, to do better. Even though our patients are at higher risk for infections, they're often under-vaccinated. This is a problem we can actually fix just by being systematic about it.
Really, the best way to handle this is to have a mental or even a physical checklist. The guidelines are clear. Annual skin cancer screenings. Make sure they're up to date on cervical cancer screening. Get a bone density scan for anyone at risk, especially if they've needed steroids. And crucially, check their whole vaccination status right when you diagnose them before you start the big gun therapies. And for our last section, let's zoom all the way out. Because we can't just treat the inflamed gut and ignore the human being who has the disease. Comorbidities and lifestyle choices have a huge impact on how people do. Think about that. 1 in 3 patients with IBD also struggles with anxiety. The weight of living with a disease that's so chronic and so unpredictable, it's just immense. Asking about anxiety and depression is a non-negotiable part of good IBD care. And let's talk about smoking. Honestly, this is one of the most impactful lifestyle interventions there is. For a patient with Crohn's disease, smoking is like pouring gasoline on a fire. It drives flares, increases the need for surgery, and it even makes our best drugs work less effectively. But the flip side is also true. Quitting can totally change the course of their disease for the better. So talking about quitting smoking, that's not just friendly advice. It is a core part of their therapy.
So that was a whirlwind tour of the 2025 Crohn's guidelines, from diagnosis to mucosal healing, from complications to treating the whole person. The real challenge, the question I want to leave you with, isn't just about memorizing these facts. It's about how you're going to build a system, a workflow for yourself, to make sure every single one of your patients gets this level of comprehensive care every single time. Thanks for watching.